Menopause is the end of menstruation. The word menopause came from Greek word mens meaning monthly and pauses meaning cessation. Menopause is a part of women's natural aging process when her ovaries produce lower level of estrogen and progesterone and when she is no longer able to become pregnant. Definition. Menopause means permanent cessation of menstruation at the end of reproductive life due to loss of ovarian follicular activity. It is the point of time when last and final menstruation occurs. Phases of menopause. Premenopause. The premenopause is the time prior to menopause, which occurs before the age of 40 years. Perimenopause, a period of women's life characterized by the physiological changes associated with the end of reproductive capacity and terminating with the completion of menopause, also called climacteric. Menopausal phase. It is the end of menstruation. The age of menopause ranges between 45 to 55 years, average being 50 years. Postmenopausal, it is defined formally as the time after which a woman has experienced 12 consecutive months of amenorrhea without period. Endocrinology of climacteric and menopause. Hypothalamo-pituitary gonadal axis. Years before menopause, with depletion of ovarian follicles, these become resistant to pituitary gonadotropins. Therefore, folliculogenesis is impaired with diminished estradiol production. There is significant fall in the level of serum estradiol from 50 to 300 picogram per ml before menopause to 20 picogram per ml after menopause. This decreases the negative feedback effect on hypothalamo-pituitary axis, resulting in increase in FSH. The increase in FSH is also due to diminished inhibin. The increase of LH occurs subsequently. Endocrinology of climacteric and menopause. Impaired folliculogenesis during this period may result in anovulation, oligoovulation, premature corpus luteum or corpus luteum insufficiency. It may even cause endometrial hyperplasia and menstrual abnormalities prior to menopause. Ultimately, no more follicles are available and some become resistant to gonadotropins. Estradiol production drops down to the optimal level of 20 picogram per ml. No endometrial growth and absence of menstruation. Estrogens. Following menopause, the predominant estrogen is estrone and to a lesser extent estradiol. Serum level of estrone 30 to 70 picogram per ml is higher than that of estradiol 10-20 picogram per ml. Compared to estradiol, estrone is biologically less, about 1/10 potent. Androgens. After menopause, the stromal cells of the ovary continue to produce androgens because of the increase in LH. However, the cumulative effect is a decrease in estrogen-androgen ratio. This results in increased facial hair growth and change in voice. As the obese patient converts more androgens into estrone, they are less likely to develop symptoms of estrogen deficiency and osteoporosis, but they are vulnerable to endometrial hyperplasia and endometrial carcinoma. Progesterone. A trace amount of progesterone detected is probably adrenal in origin. Gonadotropins. The secretion of both FSH and LH are increased due to absent negative feedback effect of estradiol and inhibin or due to enhanced responsiveness of pituitary to GnRH. Rise in FSH is about 10 to 20 fold, whereas that of LH is about 3 fold. During menopause, there is fall in the level of prolactin and inhibin. Fall in the level of inhibin lead to increase in the level of FSH from the pituitary. Ultimately, due to physiologic aging, GnRH and both FSH-LH decline along with decline of estrogens. Physiological changes. The lack of estrogen and progesterone causes many changes in women's physiology that affect their health and well-being. The symptoms of menopause due to changes in the metabolism of the body. increased cholesterol level in the blood. Hyperlipidemia or an increase in the level of cholesterol and lipids in the blood is common. This leads to gradual rise in the risk of heart disease and stroke after menopause. Osteoporosis. Calcium loss from the bone is increased in first 5 years after the onset of menopause, resulting in a loss of bone mineral density. The calcium moves out of bones, leaving them weak and liable to fracture at the smallest stress. T score is more than 2.5 SD, whereas osteopenia more than 1, less than 2.5 SD below the young adult mean. Physiological changes. Digestive system. Motor activity of entire digestive tract is diminished after the menopause. The intestine tends to be sluggish, resulting in constipation. Urinary system. As the estrogen levels decrease after menopause, the tissue lining the urethra and bladder become drier, thinner, and less elastic. This can lead to increased frequency of passing urine as well as increased tendency to develop UTI. Changes in the general appearance. Skin. The skin loses its elasticity and becomes thin and fine. This is due to the loss of elastin and collagen from the skin. Weight increases more likely to be the result of irregular food habit due to mood swing. There is more deposition of fat around hips, waist, and buttocks. Hair become dry and coarse after menopause. There may be hair loss due to the decreasing level of estrogen. Voice become deeper due to thickening of vocal cords. Changes in the genital organs. Uterus becomes small and fibrotic. The ratio Uterus becomes small and fibrotic. The ratio between body and the cervix reverts to 1:1 ratio. Endometrium becomes thin and atrophic, but with high estrogens, endometrium may be proliferative. Cervical secretions become scanty. Ovaries, they shrink in size, get wrinkled and white. There is thinning of cortex with increase in stromal cells which are secretory in nature. Vagina. The vaginal mucous membrane becomes thin and loses its rugosity and elasticity after the menopause. As the Doderlin's bacillus is absent, vaginal pH becomes alkaline. Maturation index is 10 is to 85 is to 5. Changes in genital organs. Vulva or external genital organs. The fat in the labia majora and the mons pubis decreases and pubic hair becomes sparse. Breast. In thin, well-built women, the breast become flat and shriveled, while in heavy-built women, they become flabby and pendulous. The epithelium of bladder and urethra become thin, which may cause dysuria, frequency, urge, or stress incontinence. Muscles and ligaments lose their tone, leading to pelvic relaxation and uterine descent. Changes in the vasomotor system. Hot flushes. Hot flushes are incidents where the woman in menopause gets a sudden feeling of warmth and flushing that starts in face and quickly spreads all over the neck and upper body, often associated with profuse sweating. Night sweat. They are more common at night. The sweat can be severe enough to wake up the woman from a sound sleep. The sudden waking up from sleep can cause palpitation and sometimes panic attacks. Psychological changes. There is increased frequency of anxiety, headache, insomnia, irritability, dysphagia, and depression. They also suffer from dementia, mood swing, and inability to concentrate. Dementia. Estrogen is thought to protect the function of central nervous system. Dementia and mainly Alzheimer's disease are more common in postmenopausal women. Diagnosis of menopause. Cessation of menstruation for consecutive 12 months during climacteric. Appearance of menopausal symptoms, hot flush and night sweats. Vaginal cytology showing maturation index of at least 8 is to 85 is to 5. Features of low estrogen. Serum estradiol less than 20 picogram per ml. Serum FSH and LH more than 40 milli international unit per ml. 3 values at week interval required. Weeks interval required. Management, non-hormonal treatment, lifestyle modification Includes physical activity, weight bearing, reducing high coffee intake, smoking, and excessive alcohol. There should be adequate calcium intake, 300 ml of milk, reducing medications that cause bone loss, corticosteroids. Nutritious diet balanced with calcium and protein is helpful. Supplementary calcium daily intake of 1 to 1.5 gram can reduce osteoporosis and fracture. Exercise, weight bearing exercises, walking, jogging. Vitamin D, supplementation of vitamin D3, 1500 to 2000 international unit per day, along with calcium, can reduce osteoporosis and fractures. Exposure to sunlight enhances synthesis of cholecalciferol, vitamin D3 in the skin. Cessation of smoking and alcohol. Management. Bisphosphonates prevent osteoclastic bone resorption. It improves bone density and prevents fracture. It is preferred for older women. Drugs should be stopped. When there is severe pain at any site, commonly used drugs are etidronate, alendronate, ibandronate, and zoledronic acid. Side effects include gastric and esophageal ulceration, osteomyelitis, and osteonecrosis of the jaw. Fluoride given at a dose of 1 milligram per kg for short term only also prevents osteoporosis and increases bone matrix. Calcitonin inhibits bone resorption. Simultaneous therapy with calcium and vitamin D should be given. It is given either by nasal spray or by injection. Management. Selective estrogen receptor modulators, raloxifene. Risks of breast cancer and endometrial cancer are therefore reduced. Raloxifene does not improve hot flushes or urogenital atrophy. Clonidine, thiazides, paroxetine, selective serotonin reuptake inhibitor, gabapentin, gamma amino butyric acid, phytoestrogen, soy protein. Hormone replacement therapy. Indications of hormone replacement therapy, relief of menopausal symptoms, prevention of osteoporosis, to maintain the quality of life in menopausal years, premature ovarian failure, gonadal dysgenesis, surgical or radiation menopause. Benefits of HRT: improvement of vasomotor symptoms, improvement of urogenital atrophy, increase in bone mineral density, decreased risk in vertebral and hip fractures, reduction in colorectal cancer, possibly cardio protection. Risks of HRT: endometrial cancer, breast cancer, venous thromboembolic disease, coronary heart disease, combined HRT, lipid metabolism, dementia, Alzheimer's disease. Contraindications to HRT is undiagnosed genital tract bleeding, estrogen-dependent neoplasm in the body, history of venous thromboembolism, active liver disease, gallbladder disease. Available preparations for HRT: estrogen, conjugated estrogen, 0.625 to 1.25 milligram per day, or micronized estradiol, 1 to 2 milligram per day. Progestins, medroxyprogesterone acetate, 2.5 to 5 milligram per day. Micronized progesterone, 100 to 300 milligram per day, or dydrogesterone, 5 to 10 milligram per day. Oral estrogen regime, estrogen conjugated equine estrogen, 0.3 milligram or 0.625 milligram is given daily for women who had hysterectomy. Estrogen and cyclic progesterone for women with intact uterus. Estrogen is given continuously for 25 days and progestin is added for last 12 to 14 days. Available preparations for HRT: continuous estrogen and progesterone therapy. Continued combined therapy can prevent endometrial hyperplasia. There may be irregular bleeding with this regimen. Subdermal implants. Implants are inserted subcutaneously over the anterior abdominal wall using local anesthesia. 17 beta estradiol implants, 25 milligram, 50 milligram, or 100 milligram are available and can be kept for 6 months. This method is suitable in patients after hysterectomy. Implants maintain physiological E2 to E1 ratio. Percutaneous estrogen gel, 1 gram applicator of gel delivering 1 milligram of estradiol daily, is to be applied on the skin over the anterior abdominal wall or thighs. Effective blood level of estradiol can be maintained. Transdermal patch. It contains 3.2 milligram of 17 beta estradiol, releasing about 50 microgram of estradiol in 24 hours. Vaginal cream, conjugated equine vaginal estrogen cream, 1.25 milligram daily. Progestins, medroxyprogesterone acetate, 2.5 to 5 milligram per day can be used. LNG IUS with daily release of 10 microgram of levonorgestrel per 24 hours. Tibolone 19 nortestosterone 2.5 milligram per day is given. Monitoring prior to and during HRT, physical examination, including pelvic examination, blood pressure recording, breast examination and mammography, cervical cytology, pelvic ultrasonography to measure endometrial thickness. Normal is less than 5 mm. Any irregular bleeding should be investigated thoroughly. Endometrial biopsy, hysteroscopy. Ideal serum level of estradiol should be 100 picogram per ml during HRT therapy. Serum level of estradiol is useful to monitor the HRT therapy rather than that of serum FSH. Monitoring prior to and during HRT. Duration of HRT. Generally, use of HRT for a short period of 3 to 5 years have been advised. Reduction of dosage should be done as soon as possible. Menopausal women should maintain optimum nutrition, ideal body weight, and perform regular exercise. Abnormal menopause. Premature menopause if the menopause occurs at or below the age of 40. Delayed menopause, if the menopause fails to occur even beyond 55 years, it is called delayed menopause. Artificial menopause, permanent cessation of ovarian function done by artificial means. Example, surgical removal of ovaries or by radiation is called artificial menopause. Surgical menopause, menstruating women who have bilateral oophorectomy experience menopausal symptoms. Radiation menopause, the ovarian function may be suppressed by external gamma radiation in women below the age of 40. Thank you.